If you are over 70 and your doctor tells you your blood pressure is now 120/80, I need you to pause for a moment. Because what I am about to share may challenge everything you have been told about perfect blood pressure, and it could protect you from a devastating fall. I am Dr. James Whitmore, and today we are going to talk about the real truth behind blood pressure targets in older adults, what the latest research actually shows, why lower is not always better after age 75, and how one simple test you can do at home tonight could protect your independence. Stay with me. This conversation matters. If you are over the age of 75 and your blood pressure is consistently reading 120/80, it may sound reassuring. For decades, that number has been promoted as the gold standard of cardiovascular health. But here's the important question: is that target truly ideal for someone in their late 70s or 80s? Emerging research suggests the answer is not as straightforward as we once believed. For middle-aged adults, lowering blood pressure significantly reduces the long-term risk of heart attack. The evidence in that age group is strong and consistent. However, after the age of 75, the physiology of the cardiovascular system changes in meaningful ways. Arteries become stiffer, regulatory mechanisms slow down, and the body becomes more sensitive to medications. In this context, aggressively lowering blood pressure to what has traditionally been considered perfect may not always produce the safest outcome. Large population studies following adults over 75 have shown that individuals with systolic blood pressure in the range of approximately 130/100 often experience better survival outcomes compared to those whose systolic pressure is pushed below 120. This does not mean high blood pressure is harmless. It means that overly aggressive lowering may introduce new risks. Very low blood pressure in older adults has been associated with increased rates of dizziness, fainting episodes, falls requiring hospitalization, and higher overall mortality rates in some analyses. The mechanism is understandable when you consider how blood pressure functions in the aging body. Adequate pressure is required to maintain consistent blood flow to critical organs, especially the brain and kidneys. If blood pressure is lowered too much, particularly with medication, the margin of safety narrows. Small fluctuations, such as standing up from a seated position, can cause temporary but significant reductions in cerebral blood flow. Even brief drops can increase fall risk. This is why the concept that lower is always better does not universally apply to older adults. The goal in advanced age shifts from maximizing long-term prevention at any cost to balancing protection with stability and functional independence. Blood pressure management after 75 should focus on individualized targets that protect cardiovascular health without compromising daily safety. Have you ever stood up from a chair and felt the room spin for just a second? Many older adults dismiss that sensation as just aging. In reality, it may be one of the most overlooked warning signs in blood pressure management after 70. Orthostatic hypotension refers to a measurable drop in blood pressure when moving from lying or sitting to standing. Clinically, it is defined as a decrease of at least 20 mmHg in systolic pressure or 10 mmHg in diastolic pressure within minutes of standing. On paper, this may look like a minor fluctuation. In the body of a 78-year-old, it can be the difference between steady balance and a serious fall. Here is what makes this especially concerning. Blood pressure is typically measured while sitting calmly in a clinic. If the reading is 122/76, it appears ideal. The chart looks excellent. Medication adjustments may even be praised as successful, but that same individual may experience a drop to 95/60 upon standing. The brain, which depends on consistent blood flow, receives less oxygenated blood during those moments. The result can be dizziness, blurred vision, weakness, or fainting. Why does this matter so much in older adults? Because falls are not minor events in this age group. A fall can lead to hip fractures, head injuries, hospitalization, and prolonged rehabilitation. Recovery is often slow, and in some cases, full independence is never regained. Beyond physical injury, there are psychological consequences, including fear of falling again, which reduces mobility and accelerates functional decline. Several age-related changes contribute to orthostatic hypotension. Arteries become less elastic, and the body's pressure-regulating sensors respond more slowly. Additionally, blood pressure medications may amplify the drop, especially if doses are calibrated for younger physiology. What appears to be excellent blood pressure control while seated may become instability when upright. This is why evaluating blood pressure only in a static position provides incomplete information. For adults over 70, especially those on antihypertensive medications, assessing standing blood pressure is essential. Identifying a significant drop early allows for medication adjustment or target modification before a preventable injury occurs. The real danger is not the number recorded while sitting still. It is the unrecognized drop that happens when life requires movement. What if the reason blood pressure targets should change after 75 has less to do with the numbers themselves and more to do with how the body evolves? One of the most important shifts in understanding senior health is recognizing that the cardiovascular system at 80 does not behave like it did at 50. Treating it as though it does can lead to unintended consequences. With aging, arteries gradually lose their elasticity. In younger adults, arteries expand and recoil efficiently with each heartbeat, helping to buffer pressure and maintain smooth blood flow. Over time, structural changes in the vessel walls make them stiffer. This process, often referred to as arterial stiffness, alters how pressure waves move through the circulatory system. When arteries are less compliant, slightly higher systolic pressure may actually be necessary to maintain adequate perfusion to vital organs, particularly the brain and kidneys. Another important change involves the body's internal pressure regulation system. Specialized sensors located in the carotid arteries and aortic arch continuously monitor blood pressure and send rapid signals to the brain to adjust heart rate and vessel tone. In younger individuals, this reflex is nearly instantaneous. With advancing age, the sensitivity and speed of this response decline. As a result, sudden positional changes such as standing up may not be compensated for as effectively. If resting blood pressure is already lowered aggressively, the body has less reserve to maintain stability. Medication metabolism also shifts significantly with age. Liver and kidney function naturally decline over time, even in healthy individuals. These organs are responsible for breaking down and clearing many antihypertensive medications. When clearance slows, drug concentrations may remain elevated longer than intended, amplifying blood pressure-lowering effects. A dose that is appropriate for a 55-year-old may produce excessive lowering in an 82-year-old. These physiological changes explain why a universal blood pressure target does not always serve older adults well. The goal is no longer simply to reduce numbers as much as possible. It becomes a careful balance between reducing long-term cardiovascular risk and preserving immediate functional stability. Understanding how aging reshapes the cardiovascular system is essential for setting realistic, individualized blood pressure goals that protect both organ health and day-to-day safety. If the safest blood pressure for older adults is not the lowest possible number, then what is the ideal range? This is where nuance becomes essential. The evidence increasingly suggests that for adults over 75, there is a physiological sweet spot where risk is minimized without compromising stability. For generally healthy adults between 65 and 74, a systolic range of approximately 130 to 140 appears to provide strong cardiovascular protection while maintaining adequate organ perfusion. As individuals move into the 75 to 84 age group, research indicates that a slightly higher range, often between 135 and 45 systolic, may be more appropriate. For those over 85, or individuals who are frail, living with multiple chronic conditions, or at higher risk of falls, a systolic range of 150 may offer the safest balance. Why would a moderately elevated pressure be protective? Because blood pressure is not just about preventing stroke or heart attack. It is also about ensuring sufficient blood flow to the brain, kidneys, and other critical organs throughout daily movement. When systolic pressure falls too low in advanced age, the margin for error narrows. Standing, walking, or even mild dehydration can tip someone into symptomatic hypotension. Diastolic pressure deserves equal attention. In older adults, diastolic values consistently below 60 to 65 can reduce coronary perfusion, particularly during the heart's relaxation phase. Maintaining diastolic pressure in a range closer to 70-85 often supports better myocardial blood flow and overall cardiovascular stability. The key principle is balance. Pressures consistently above 150 associated with increased stroke and cardiovascular event risk. Pressures below 120 systolic, especially when medication-driven, may increase fall risk and organ hypoperfusion. Between those extremes lies a zone associated with better survival and functional outcomes in older populations. This range is not rigid or identical for everyone. Health status, kidney function, cognitive function, fall history, and medication tolerance all influence what is optimal. But understanding that moderate control may outperform aggressive lowering allows clinicians and patients to shift away from perfectionism and toward individualized, physiologically appropriate care. What if a simple 3-minute measurement at home could reveal more about your true blood pressure safety than a single office reading? Many older adults rely entirely on clinic measurements, yet those numbers represent only one moment in a controlled environment. Real life is dynamic. You stand, walk, bend, and change positions constantly. Your blood pressure must adapt to all of it. Home monitoring provides a clearer picture of how your cardiovascular system behaves throughout the day. For adults over 70, especially those taking antihypertensive medications, this is not merely helpful, it is essential. Blood pressure naturally fluctuates based on activity, hydration, stress, and time, and a reading of 138/82 in the morning may differ significantly from an evening value. Averaging readings over several days offers a more accurate representation than isolated clinic measurements. The most important component of home monitoring in older adults is checking for orthostatic changes. After resting quietly for 5 minutes while lying down, measure and record your blood pressure. Then stand up and measure it again immediately. If the systolic pressure drops by more than 20 points or the diastolic by more than 10, this may indicate orthostatic hypotension. That drop suggests your body is struggling to maintain adequate cerebral perfusion when upright. Why is this so important? Because many medication regimens are adjusted based solely on seated readings. Without evaluating standing measurements, clinicians may unintentionally intensify treatment that appears successful on paper but compromises stability in daily life. Identifying a significant positional drop allows for thoughtful medication review. Sometimes a small dose adjustment, a change in timing, or modifying the target range can reduce symptoms without sacrificing cardiovascular protection. Home monitoring also empowers patients. It transforms blood pressure management from a passive experience into an informed partnership. Documenting readings over 2 weeks and sharing them with your healthcare provider supports evidence-based discussions. It shifts the conversation from reacting to isolated numbers toward understanding patterns and physiological responses. The value of this simple practice extends beyond numbers. It enhances safety, preserves mobility, and reduces preventable risk. In older adults, knowledge gained from consistent home monitoring can directly influence decisions that protect both independence and long-term health. Is blood pressure management about achieving a number or about protecting a person? This distinction becomes critically important in adults over 75. Modern guidelines provide valuable frameworks, but they cannot replace individualized clinical judgment. Two individuals of the same age can have identical blood pressure readings and require entirely different management strategies. Consider the variables that influence cardiovascular risk and treatment tolerance in older adults. Frailty, kidney function, cognitive status, diabetes, prior cardiovascular events, fall history, medication burden, and overall functional independence all shape what is appropriate. A systolic reading of 148 may be concerning in one person and relatively acceptable in another, depending on these factors. Numbers alone cannot capture the complexity of aging physiology. Aggressively lowering blood pressure without considering the whole clinical picture may reduce long-term stroke risk but increase immediate dangers such as falls, dizziness, or worsening kidney function. Conversely, ignoring persistently elevated readings in a robust older adult with few comorbidities may expose them to preventable cardiovascular events. The goal is not minimal numbers, it is optimal balance. Treating the patient rather than the number requires conversation. It means discussing symptoms openly, including subtle ones such as fatigue, mental fog, or lightheadedness when standing. It requires reviewing medications thoroughly, especially in individuals taking multiple prescriptions. Polypharmacy is common in older adults, and each additional medication increases the potential for interactions and side effects. Functional status should guide decision-making. An active 82-year-old who exercises regularly and manages daily activities independently may tolerate moderate blood pressure control well. A frail 82-year-old with limited mobility and recurrent falls may benefit from a more conservative approach. Both deserve individualized targets aligned with their health priorities. This approach also respects quality of life. The purpose of treatment is not simply to extend lifespan at any cost, but to preserve independence, cognition, and stability. When clinicians and patients focus on the broader context rather than isolated readings, blood pressure management becomes more precise, safer, and aligned with the realities of aging. For decades, we believed that lower blood pressure was always better. For middle-aged adults, that is often true. But after 75, the equation changes. Too high is dangerous, but too low can be just as dangerous. The goal is balance, protecting your heart while preserving your brain, your stability, and your independence. You are not just a blood pressure number. You are a whole human being whose physiology evolves with age. Have informed conversations, ask thoughtful questions, advocate for individualized care. Because the real goal is not perfect numbers. It is a longer, safer, more independent life, and that is worth protecting.